computer back there.
Alright, so before we do the dental work, obviously you need a patient that's going to cooperate and that's going to be numb. Alright, so there's a couple different techniques for anesthesia. Everybody may use a different technique, but usually the main ones are, you're going to use a topical, which is on the, you're going to put some sort of jelly on the gum to numb up the gum. And then you're going to use either an infiltrate, which means you're just going to flood the area outside a tooth, or you're going to do the other one, which is a block. It means you're going to hit the nerve and you're going to block that whole side. Okay, so you either infiltrate on outside of a tooth or you block, and that numbs up. Like if you're having with an epidural, that's an epidural block where they give you the epidural and it blocks your waist down. Kind of same thing here. If we're doing a mandibular block, we're going to give an infraorbital block, and it's going to numb up that whole lower left side plus the tongue because you get the lingual nerve. You do the right side. And then on top there's three different blocks: posterior, middle, and anterior block. Okay, so we'll go over those. Okay, so local anesthesia is a direct application of anesthetic to oral tissues. Specifically designed anesthetics can be applied directly to the tissues to provide a topical anesthesia or injected into the tissues to achieve profound local anesthesia. Okay, so topical. Any questions on the topical, what it is? Topical means on the surface. Used in dentistry to provide superficial anesthesia to mucous membranes within the oral cavity. So if you put it on your tongue, it's going to numb up your tongue. You put it on the lip, it's going to numb up the lip. Patients sometimes will swallow some and they'll feel like their throat is a little numb. But it's just on the surface, okay? Nothing underneath. The numbing sensation only occurs on the surface of the oral mucosa. It is not effective to the underlying tissue, so it's just very superficial. The primary use of topical anesthetic is to minimize the needle stick. Okay, that's what patients fear the most. They're afraid of the needle. And if you can minimize that, it makes it a little bit more comfortable. Okay, so that's on the test. Topical anesthesia is used to minimize the needle stick. Okay, it can also be used for tooth desensitization or decrease the gag reflex during dental impressions. You can get them back there, get some on a swab and get way back there and numb up the roof of their mouth on the uvula area, and that'll minimize the gag reflex. And I think we talked about last week where one of our hygienists that was temporary here, she used salt, and I've never done it, but she put salt in the back of the patient's tongue and was able to get a full mouth series of x-rays. So learn something new. So concentrations. The concentration of topical anesthetic is generally higher than local anesthetics and range from 5% to 20%. And that's what benzocaine is, or Oragel. It's usually either 15 or 20% benzocaine. So what you're putting on your baby's teeth when they're teething, that's what it is, topical anesthetic. Can be supplied in a gel, liquid, ointment, or a spray. Okay, arceticane is a spray, tastes nasty. Hurricane is another spray, you just spray it back there in the area, but that just goes all over. Patients really hate that. And then there's a gel or a cream, and then this is the one that we normally have, this kind of gel. They just dip a little Q-tip in there. So know that there's different methods of applying it. Application of the topical anesthetic, review the patient's medical history. Again, some patients may be allergic, or they don't like it, or it makes their heart race, or whatever. Make sure that you can apply it. You want to dry the area. If you don't dry it, if you got saliva there and you put it, it's just going to dilute it and it's not really going to work. So use a cotton swab or a cotton roll, dry the area, and then put it. And then I normally leave the cotton swab in there and they can close so that it's staying in the area a little bit better. Apply the topical anesthetic using a small amount of anesthetic to the cotton-tipped applicator. And if you look in the drawers here, sometimes you'll see it like that. And what the girls use is actually when, and we'll show you, I think Dr. Cervantes showed you the back of the needle cap. Did he show you needles right now? Here? No. Okay, that's next. When you open a needle, what's in the back, that little cap, they get some of this and they use that and they put that on the tray table. Okay, so they kind of recycle that material there a little bit, so they use it. Or you can just put it on a swab like this. Okay, placement of the topical anesthetic injection sites. Okay, so these are the sites where you're going to apply it. Okay, patient, if you're doing tooth number 2, you're going to put it somewhere. If you're doing tooth number 6, you're going to put it in a different spot. You don't just swab the whole area, you put it in a particular spot. So topical anesthetics are placed in the following locations prior to the local anesthetic injection. Why?
To minimize the needle stick.
Okay, the first type of anesthetic is infiltration. Okay, especially in upper tooth. We're going to infiltrate, which means we're just going to flood the area with, if I'm just doing one tooth, I'm just going to flood the outside of that area to numb up just that one tooth, or just that one area. I don't need to numb up the whole upper right side. So that's infiltrate, just flood. Okay, so if we're doing tooth number 8, and Dr. Cervantes' assistant will put the topical anesthetics. Mine don't, they don't. I wait until I put it. But for Dr. Cervantes, Yesenia will dry and put the applicator right in front of the tooth, up by the gum in the vestibule. Okay. If it's the block, okay, for tooth number 8, we're doing an anterior superior alveolar block, it's called ASA. Just mesial to the maxillary canine and apex in the mucobuccal fold. Okay, so ASA is right here. Canine way up by underneath your nose. Okay, and there's an MSA. That's the maxillary second premolar in the mucobuccal fold. Okay, so a little bit further back in this area. Okay, and then you have a PSA, which is back around the second molar. Okay, so you start canine, second premolar, and the second molar. Those are your 3 blocks for your upper. Okay, so depending on what they want to do, if they're just doing one tooth, you infiltrate on tooth number 3, or tooth number 14, tooth number 7. If they're doing 2 or 3 teeth, then you're going to block. And if you're doing tooth number 2, 3, and 5, then you're going to block in the back and you're going to block in the front, because those 2 are different nerves. So you'll have to apply 2, and we'll cover that in the lab. Nasopalatine, that's not fun. You remember where the nasopalatine foramen is? Nasopalatine right behind your 8 and 9. Okay, that's not fun. Right behind your incisors. So you can put numb up there. Greater palatine, that's a little bit further back behind the second molar on the palate. Okay. So these you have to know, okay? The blocks. Where to apply the topical. So the question will say which maxillary block is used or is placed in the maxillary canine. So you'll put ASA, anterior superior. Which one is on the second premolar, the middle, and which one is on the second molar, the posterior.
Are you highlighting these?
Yes. Okay, so again, the ASA is apex of the canine, MSA is the apex of the second premolar, and PSA is second molar, or around the back. It's right where the vestibule kind of falls off into nowhere. I know I didn't give you your study guide.
What about the nasopalatine and greater palatine?
No, usually not. Just the MSA, PSA, ASA. Okay, so then the nasal palatine is right behind the central incisors, greater palatine behind the second molar. Okay, so this one, which one would this one be? Where are we at? What's this? Canine? This is first premolar, second premolar, so this one would be MSA. Oops. Thought I was going to put MSA, but this one would be MSA, middle superior alveolar. ASA would be up in this area. Okay, now those were for the upper arch. For the lower arch, okay, infiltration usually you can do on older patients, maybe lower front. Doesn't work really well, but you can try. Especially if they have gum disease, it'll work better because there's not much bone it has to go through. But usually on the lower, infiltration is not really that effective, but you can try. Usually it's an inferior alveolar. Okay, so up on top you had posterior, then superior alveolar, middle superior alveolar, and anterior superior alveolar. So superior meaning top. Okay, not that it's better. Superior meaning the top. Okay, the lower means inferior, meaning the lower. Okay, so not that it's not as good, it just means it's the lower. So the inferior alveolar is distal, superior, and slightly lingual to the retromolar pad. Where's the retromolar pad, if you guys remember? You guys put your tongue distal to your second molar on the bottom, you'll feel a little bump where your wisdom tooth used to be or is. And you'll feel a little bump that sometimes covers the back end of the second molar. That's the retromolar pad. So you're going to go distal, just superior, and on the lingual side. Okay? And I'll show you a picture right now. The buccal block is just outside of the second molar. The mental is right here.
Do we need to highlight any of this?
Yes.
Which ones?
Oh,
Why aren't you starting?
I don't know. I'm asking myself that same question. Doc, can you get the study guide?
You just printed it?
Yeah, it should have printed. Okay, I don't know why they're not started. So here is the lingual nerves, and the inferior alveolar nerve starts to come right here. Okay, it comes out of your skull, and it's in soft tissue, and then it goes into your jaw in the foramen right here. Okay, so this is when we're numbing up, this is where we're shooting. We're trying to, we put our fingers like this and we try to shoot in this area somewhere. Okay, and just flood that area. Okay, that sometimes if we do hit that nerve, the patient will go, ah, jump, and they get like a shock if we do hit it. Okay, so here this, again, here's the foramen. And so the nerve is coming out here and it goes into the jawbone right here, so we want to shoot somewhere in this area to flood it. So it's going to, if we block it right here, numb it here, the whole left side is numb, from wisdom tooth all the way to 24. Okay, and then you've got the lingual nerve running right around it, and so it normally goes, and your tongue is numb too. Okay, it looks something like that inside the mouth. So inferior alveolar nerve block. Okay, so you would put right where that needle is, that's where you would put the topical anesthetic. Okay, your buccal nerve block is right outside the second molar on the cheek side. These are the lower teeth. You're retracting the cheek. And it goes, you just go and you'll hit the bone right away. You just hit the bone. And you just squirt a few drops in there, and that gets, what this numbs up is the tissue from the second molar to about the premolar. Okay, and then this is the mental. You guys know the mental foramen right here. That's another nerve block you can go. And you just inject right here, put in about half a carpule or a whole carpule, and you push. You hold your finger or your thumb there for about a minute and start to push that liquid into that foramen. Okay, and you try to get the nerve inside the bone. You push the liquid in through that foramen and try to block the nerve from here forward. So sometimes I use that if I'm working on a lateral here or a canine and I don't want to block the tongue and everything, I'll squirt right there and hold it. Works, I'd say 50% of the time. Sometimes I still have to go back and block the hole. Okay, so again, you've got the buccal right outside the second molar, your mental right at the apex of the second premolars on the bottom. Then your inferior alveolar, just superior, distal, and lingual to the retromolar pad. Okay, local anesthesia gives you the loss of sensation to that localized body part. The ideal properties, okay, know these. This one is started. Rapid onset. Okay, you inject it and it's going to start working right away. It's going to last anywhere from 1 to 4 hours. Some are 7 hours or longer. Depends on the anesthetic you use and what you need it for. You don't want to use an anesthetic that lasts 7 hours if you're going to do a procedure that's going to last 20 minutes. So that's why the material that we use, it actually, on the tooth, it gives you about half an hour. It stays on your tissue, 2 to 4 hours though. But the tooth anesthetic gives you, maybe an hour. It doesn't last unless you nick the nerve. It could be irreversible, and that's a risk that we take. And I've had that happen to me once, but it slowly came back. So when I injected, I probably hit the nerve, and the patient came back and said, oh, my lip is still numb. And that's what it was. It was damaged with the anesthetic needle, and slowly it regenerated. Unless you cut it, unless you cut the nerve and sever it, usually, it regenerates. It's low toxicity, so it's normally you can give enough to anesthetize. Low allergy. Okay, not many patients are allergic to the anesthetic. Some patients are allergic to the preservatives that are put inside sometimes, but not a lot of patients are allergic. Some patients say they're allergic because they have heart palpitations, but that's usually not the anesthetic. It's the epinephrine that's in it. And I'll talk about it right now. It lasts about a year and a half, and it's not that expensive. Okay, so any of those, I think it says how many you need to know, 3?
I know, it's the ones that are filled in the blank.
Yes. Somewhere it says how many you need to know.
It's 4.
4? Yeah, list 4 of those. Oh, and it's compatible with vasoconstrictors, and I'll talk about what those are. Okay, the concentration and dosage, the main ingredients of the cartridge is the local anesthetic. And again, they add some preservatives, sodium chloride, distilled water, vasoconstrictors, and preservatives. The percentage of the anesthetic is 2% to 5%, and that's what we need to pay attention to. The label of the cartridge lists the anesthetics and if it has a vasoconstrictor percentage. The vasoconstrictor is what allows the anesthetic to stay in that place longer. If you don't add the vasoconstrictor, it doesn't last, and you've got to give more anesthetic and more anesthetic, and it's not good. Okay, each carpule is about 1.8. The dosage is dependent on the type, the use of vasoconstrictor, what you're numbing up, and the size of the patient. You're not going to give the same amount to a little kid than a 200-pound football player. Physical health of the patient, that is really important. Patients that have cardiac problems, you're not going to give them the same amount or the same type. Okay, so duration. Again, we select the anesthetic usually on the amount of time that we need. Okay. The duration varies significantly between types and concentrations of anesthetic. A short one is going to give you 10 to 30 minutes without a vasoconstrictor. Okay, so we don't add epinephrine. Intermediate, about an hour with, and long, about 90 minutes of, this is tooth anesthesia. And again, on the soft tissue, it lasts longer. This is usually the one that we use, about 60 minutes, but it'll last 2 to 3 hours in the soft tissue. So we normally get about an hour of anesthetic with the 2% lidocaine. So if you don't add vasoconstrictors, if you just add anesthesia, just lidocaine without anything, it increases the blood supply, the dilation of the blood vessels. So it's going to wash away soon, and you're going to have to give more. And it's going to go away soon, you're going to have to give more. And that's not good because you're giving too much anesthetic to a patient. So they add epinephrine to it because the epinephrine shrinks the blood vessels and it keeps the anesthetic in there. It shuts down the blood supply and it keeps the anesthetic in that site longer. So that's why they add vasoconstrictors, so you don't have to give as much. One, it stops bleeding, so hemostasis, because it closes the blood vessels. So you have less flow of blood to the injection site, so it stays longer. The anesthetic is absorbed more slowly into the bloodstream, so it lasts longer, it's more effective, and you don't have to give as much. So there's less risk of giving too much. Again, this is what you have to pay attention to, because it is epinephrine. Epinephrine is basically adrenaline. Adrenaline is what causes your blood or your heart to race, and kind of when you get scared and your heart starts pumping really quick, because your brain just released a whole bunch of adrenaline to tell you to run because there's a dog chasing you. Okay, so again, you want to pay attention because you don't want to give too much epinephrine to somebody that has high blood pressure or has any heart problems, severe cardiovascular disease, hyperthyroid. Okay, so those three: hypertension, cardiovascular disease, or hyperthyroid, which is Graves' disease. The concentration of vasoconstrictors, higher the ratio, the lower the anesthetic. So 1 to 20,000, 1 to 50,000. This is the one that we use, is the most common one, 1 to 50,000. And 1 to 200,000. Okay, so those, again, pay attention to the colors. This is the one that we have, 1 to 100,000, 2% lidocaine. That's the most common one that will be out there. But again, there's Marcaine. This one has 1 to 50,000. I use that to stop bleeding sometimes. I think we have very few of that. Methods of administration, again, I talked infiltration is just flooding the area, usually on upper teeth. And then the block, which is the nerve block. If you're doing 2 or more teeth, you want to block the nerve somewhere in the back so that it numbs everything in the front that you're working on. Okay? Yeah. Questions? Yes. No questions. We'll break for lunch and we'll do the lab part of the anesthetic lecture when you get back. And then we'll do the lab. Again, there's none in the lab, not too much assisting, mostly recognizing the instruments. We will place anesthetic on each other if you guys want, or on the mannequin. I think it's best on each other, but you guys decide. And then Dr. Schmattes is doing a root canal on any volunteers? There you go.
All right.
Doing a root canal on Bethany.
I took